Hello everyone. Today our topic of discussion is the hemodynamics and operating room decision making, how TE can help to manage in your routine cardiac cases. So in pre-CPB or baseline examination, the first thing you will have to see how is the LV and RV is doing. So in LV and RV function, first you will have to see how is the chamber size, what is the wall thickness, any regional wall motion abnormality, is gross systolic and diastolic function, and movement of interatrial septum and interventricular septum. Second, we'll have to look for the valve function. How is the leaflet mobility, whether it's thickened, whether it's calcified, how is your valvular apparatus, what is the valve area. By putting the color Doppler, you can know whether if there is any stenosis or regurgitation, and we'll put the Doppler interrogation to know any pressure gradient or PhD in case of any regurgitation. Next thing, we'll examine if there is any intracardiac shunt, most commonly as a PFO or ASD or any VSD or any post MI VSR or any kind of fistulous connection. Next thing is intracardiac thrombus or mass. We'll have to look for any spontaneous echo contrast in any chamber. We'll always have to check for the LA appendage because that is the most common site for formation of any thrombus, or is there any mass or any tumor, and whether its relationship with any wall or any valve, whether it's attached or not. To judge about the volume status of the patient and to know whether the patient will be responsive to fluid or not, we can examine left ventricular and diastolic area, LVOT VTI, IVC diameter, SVC collapsibility index, or whether the patient is having grade 3 diastolic dysfunction, because we know that up to grade 2 of diastolic dysfunction the patient will be tolerant to the fluid, but if the patient is having grade 3 diastolic dysfunction, patient will not be intolerant to the fluid. And final but not the least is the aorta. We'll have to examine with how is the dimension, whether it's dilated, whether it's narrowed somewhere, if there is any dissection flap, and one of the most important, whether there is any atheroma or mobile atheroma, which is more likely to embolize to any organ, most commonly in the brain. So we will see one by one. At first, the most important function of your heart is your systolic function, which is judged by your stroke volume. So you'll put the pulse width Doppler at about 0.5 to 1 centimeter proximal to the aortic valve into the LVOT in the deep transgastric 5 chamber view, or you can put also in the transgastric long axis view. That will give you a LVOT VTI. And the LVOT VTI, if it is less than 15 centimeter, it actually indicates low stroke volume, whereas if it is more than 20 centimeter, it indicates high stroke volume. But if you multiply your LVOT VTI into LVOT cross sectional area, that will give you the stroke volume. But always remember the pitfalls of this mechanism. If there is a significant AR, if arrhythmia or intracardiac shunt of the patient is having AS, this equation will not give you proper insight to the stroke volume estimation. Next thing you want to know that how much your left side of the heart is congested. So that will tell you by estimation of left atrial pressure or PCWP, which is a surrogate of LV end diastolic pressure in absence of significant mitral valve disease. Now we cannot examine LA pressure directly, or we cannot measure by LA pressure directly by your transesophageal echocardiography, but we can do a rough estimate by seeing the movement of your interatrial septum. If it is towards RA, both in systole and diastole, that means that is indicative of a high LA pressure. Or if it is the both towards your LA, both in systole and diastole, that means that will indicate about high RA pressure. Whereas in case of normal, there is a mid systole, there is a brief reversal towards your LA, whereas in case of diastole, it is grossly deviated towards right atrium. Now you want to have an insight whether your right side of your heart is also congested or not. That will be determined by your estimation of your RV systolic pressure, that means your PA systolic pressure. that will be determined by your Vmax of your TR jet examined by continuous wave Doppler, put in mid-esophageal modified bicable tricuspid valve view, where you will get the PS systolic is equal to 4 into TR Vmax square plus CVP, that means your RA pressure. Now the fluid responsiveness is assessed by TOE by two parameters, that is static parameter and dynamic parameter. Static parameter means, that means you'll have to freeze the image in particular uh, stage of your cardiac cycle and then you'll have to measure. Dynamic parameter means that you'll have to do a continuous measurement throughout the respiratory cycle. In static parameters, what are the things you have to examine? There is left ventricular end diastolic area or volume, or end systolic obliteration of your LV cavity. That will give you a rough estimate of your fluid responsiveness. And in your dynamic parameter, if the patient is having any in mechanical ventilation, that means you will have to see respiratory variation in your LVOT VTI, respiratory variation of LVOT Vmax, SVC collapsibility index, and passive leg raising test. And the patient, if the patient is having spontaneous breath on mechanical ventilation or unintubated patients, you can do a passive leg raising test. Now, superior vena cava collapsibility index, how will you do it? You will do it by uh, going to the ascending aorta short axis view, where you will get this kind of image. You will get a cross section of your ascending aorta and your main pulmonary artery and your right pulmonary artery, and there you will be able to see your SVC, where you will have to rotate your TE probe more towards your right to get your SVC more towards your center of the image, and then you will change the omniplane angle to 90 degree to create a cross section of your uh, longitudinal cross section of your SVC, and you will put a M mode on your SVC, and then you'll get a waveform like this with the respiration. So you'll get a maximum SVC diameter and your minimum SVC diameter. So you'll, the formula is SVC the max minus SVC mean divided by SVC max into 100. That will give you a SVC collapsibility index. Now this is the formula of your SVC collapsibility index, that is SVC max minus SVC minimum divided by SVC max into 100. So if it is more than 36%, that means the patient is having fluid responsive, and if it is less than 20, that means the patient is having adequate intravascular volume, and 20 to 36% it is indeterminate zone. Now this is the indices of how LVOT Vmax and LVOT VTI gets variable with your inspiration and your passive leg raise. If there is 12% increase in LVOT max and 9% increase in LVOT VTI with inspiration, and if there is a 10% increase in LVOT VTI with passive leg raise to 45 degree, that suggests fluid responsiveness. So this is the formula of change in LVOT Vmax, where LVOT Vmax minus LVOT minimum divided by LVOT V mean into 100. Now, how to identify whether the patient is having hypovolemia or the patient is vasoplegic? It is best assessed in the transgastric mid-papillary short axis view. It is distinguished by left ventricular end diastolic area, which is a normal of 8 to 14 centimeters square. You can see by this image, in case of your normal and your in your vasoplegic, your left ventricular end diastolic area is the same. Whereas in case of your end systole frame, you can see that your hypovolemia and your vasoplegic frames are similar. So by looking at an example in our next, so this is the left one, this is the normal, this is your hypovolemia. You can see the LV endostolic area seems to be less, whereas this is a case of a vasoplegia where the LV endostolic area is near to the normal patients, but LV is also completely getting emptied, just like your hypovolemic patients. So this is how by eyeballing you can distinguish hypovolemia and mesoplasia. Now, in this example, how will you identify which is one is hypovolemia and which one is LVH? Now you can see that in case of your LV hypertrophy, your internal diameters are also diminished, just like your hypovolemic patients. But you can distinguish by your wall thickness. In this three video loop, you can see this is your normal LV, this is your concentric hypertrophy, this is your eccentric hypertrophy. In a concentric hypertrophy, you can see there is almost obliteration of your internal cavity by your increased muscle mass. In case of eccentric hypertrophy, you can see there is an increased volume inside the LV. That means your left ventricular endostolic area is more, but there is also eccentric hypertrophy. So though the wall seems to be thinned out, but it is actually hypertrophied, and the muscle mass is frequently even more than your concentric hypertrophy. Now, to determine the regional wall motion abnormality of LV wall relative to the coronary artery distribution, if you see in a four chamber view, in your lateral wall, it is mostly supplied by your LAD and LCX. This blue marker is done by your LAD, and your peach color is for your LCX, and a green color is your for RCA. So your septum is supplied by your LAD and your RCA, whereas in your mid-esophageal two-chamber view, your anterior wall and your apical part of your inferior wall is supplied by your LAD, whereas your inferior wall above your apical level is supplied by RCA. And whereas in case of your in case of your mid-esophageal long axis view, the anteroseptal wall is supplied by your LAD, and your inferior lateral wall is supplied by your LCX. And this is your 17 segment of your mid-esophageal basal view, transgastric basal, transgastric short axis, mid-papillary short axis, and transgastric apical short axis. So these three segments will actually give you the 17 segments, uh, which is supplied by different branches of LAD, LCX, and RCA. So this distribution should be very much in our mind while knowing which part of your wall is not moving. So like this image, you can see there is a hypokinesia of this part of your wall in your mid-esophageal fourth chamber, whereas in your mid-esophageal long axis view, you can see that this wall is also not moving, and your transgastric short axis view, you can see the portion between your two papillary muscle in your lateral wall is also not moving. So all these three image is actually corroborative of injury to the LCX, or there is a LCX ischemia, LCX region ischemia. After knowing which wall is having a regional wall motion abnormality, it is also important to know whether you are dealing with a acute ischemia or chronic ischemia. So by knowing the chamber size and wall thickness or presence of any scar, you can actually see the difference in between these two images. Here the wall thickness is normal and your chamber is not enlarged. So this is the case of your anteroseptal ischemia in this portion of your wall, uh, and also this is a acute ischemia, whereas in this image or in this loop you can see the chamber is dilated, there is a formation of scar is anteroseptal, and also the wall is also thinned out in this area. So we'll have to look for if there is any defect in the wall. So we can see over here there is a aneurysmal formation in this LV wall. We have to see whether there is any intracardiac shunt. That is, in a acute MI patient, you can see there is a formation of your there is a gap showing in an interventricular septum. By putting a colored Doppler, you can see there is a flow through that. So this is a case of VSR. In a short axis view, transgastric mid-papillary short axis view, you can see there is a gap in between in your anteroseptal wall. Now this is a proper gap that we are able to see, and the same video with the colored Doppler, you can see the flow through the VSR. Now hemodynamical instability has many things to do with your acute MR. So you can see over here there is a in a acute MI patient there is a avulsion of your posteromedial papillary muscle. This is a avulsion from your posteromedial papillary muscle, and uh, this is actually floating in the LA, and also there is a flail of posterior mitral leaflet. Now in this image you can see there is a avulsion of your anterior papillary muscle, and there is a floating of your papillary muscle of with your anterior mitral leaflet into the LA. Now if you are planning for your mitral valve repair, you have to examine these predictors of systolic anterior motion of your anterior mitral leaflet into the LVOT during systole, so producing any LVOT obstruction. So what are the predictors of SAM? If the AML length is more than 2 centimeter, if the PML length is more than 1.5 centimeter, and if the AML is to PML length ratio is less than 1.3, C-sept. C-sept means it is a distance between your septum and your distance between your septum and your coaptation. If it is less than 2.5 centimeter, if the automitral angle is less than 120 degree, and septal thickness is more than 1.5 centimeter. If all those things are predictors of SAM, and these are to be examined during end systole, and whereas another parameter LV end diastolic diameter, if it is less than 4.5 centimeter, that means LV size, internal cavity size is smaller, and this parameter has to be examined in your end diastole frame. So all are the predictors of SAM. So these are the predictors. If these are present, any of these are present, that means there is a more chance of your systolic anterior motion after mitral valve repair. So this is an example of SAM causing LVOT obstruction. You can see over here there is a MR and also flow acceleration in your LVOT. In this image, in the right sided loop also you can see over here there is a eccentric MR, and also there is a flow acceleration in your LVOT. Tricuspid annulus measurement is your routine measurement in case you are addressing a mitral valve pathology with replacement or repair, whether you have to address the tricuspid uh, valve or not, and if the patient is having concomitant RV dysfunction, having severe or moderate TR, whether you have to address the tricuspid annulus. If it is dilated by more than 4 centimeter or more than 25 millimeter square by meter square of your body surface area, that means the patient may require a tricuspid annuloplasty. Now let us go through few clips of your RV dysfunction. So this is a case of a mitral stenosis of RV pressure overload. You can see in the midesophageal 4-chamber view, there is a shifting of your interventricular septum uh, in your diastole more towards your LV, and also there is a gross dilatation of your RV, and you can also see there is a hypertrophy of your RV myocardium, and also the subvalvular apparatus are hypertrophied in your transgastric mid-papillary short axis view rotated towards right. Now this is a clip of primary pulmonary hypertension with RV pressure overload. Here also you can see your RV is dilated, your left sided chambers are compressed by your RA and RV, both are dilated, and also you can see the shifting of your septum towards your LV. Now this is a case of a your RV volume overload. Now you can see the RV is also enlarged over here, but the difference is that the RV wall is not hypertrophied here. So the chamber size is just like your previous clips. In this patient of your RV systolic failure or inferior STEMI, you can see over here your RV wall is not moving at all, and your inferior wall is not moving in transgastric mid-papillary short axis view. And these are transgastric basal view. You can see over here the RV free wall is not moving. Now T is very much valuable for your venous cannulation, especially for your minimally invasive or robotic cardiac surgery, where for venous cannulation your uh, mid-esophageal bicaval view is the view of choice, where you can see your wires passing through your IVC through your RA towards your SVC, just like this. And also you have to be very much sure that the wire is not crossing the septum, and also not crossing the tricuspid valve, uh, by looking into mid-esophageal modified bicaval view. Here we can see in the similar view, we can see the venous cannulation and its depth. If the patient has been put in a one drainage cannula from your IVC, it has to be put in the your SVC RA junction so that it can drain both your SVC and the IVC. If the patient is put two drainage cannula, then the superior cannula has to be put in the SVC RA junction and your inferior cannula just beyond your IVC RA junction into the RA cavity. So this is how you get confirmed by your TE by the positions of your venous cannula. Just like that, your aortic cannula, but you cannot see your aortic cannula per se over here. You can see only your aortic guide wire, because aortic cannula size is much smaller and it remains mostly up to abdominal aorta. So this aortic cannula cannulation, before you put the aortic cannula, you have to be very much sure whether your guide wire is inside the lumen of your aorta. In this image, you can see over here in the right sided image, there is a formation of a dissection. So this is your true lumen, this is your false lumen, and the guide wire has passed into the false lumen. So but if you pass explain through that wire, you can see over here in that long axis image, you cannot see any dissection flap. So by this you can know that always try to put both the views, both the cross sections and your long axis view, short axis and long axis view, so that you can see the guide wire not passing through any kind of dissection or doing any dissection in the wall. Now we have to see if there is any atheroma in your descending thoracic aorta. Now you can see over here there is a fixed atheroma and a calcification over your aortic wall, and also there is a mobile atheroma also in your descending thoracic aorta, because these patients are more likely to have embolic stroke. Now what are the things you have to see in the post CPB? Number one is intracardiac air, valve assessment if you are putting any valve replacement or valve repair, residual shunt if you're doing any ASD or VSD closure, if the patient's volume status and filling, LV and RV function, if new WMA has developed or not, if there is any dynamic LVOT obstruction, and also pleural and pericardial effusion. Now, dearing is the most important function of your TE in your post-CPB examination, where you will have to look for any intracardiac air entrapped in the left side of your heart, and you have to look for your midesophageal fourth chamber view, midesophageal RV inflow view, and midesophageal long axis view. Uh, and you have to be very much sure that in left atrium, the most common site where air gets entrapped is right upper pulmonary vein, septum, and appendage. In your left ventricle, make sure there is no air bubble entrapped in your apex. And also aortic root, RCA sinus is the most superficial structure while the patient is life supine, because always remember the air can be just do a inferior wall ischemia, and arrhythmia if the air goes into the RCA. And here in the left side of the image, you can see there are multiple small micro air bubbles. And but in the right side of the image, in the midesophageal RV inflow outflow view, you can see over here there is a large air bubble that you can see over in the septum in the anterior part of your left atrium, and it is forming an acoustic shadow also. So this is a air bubble that we have to be very much careful that these are not present in the heart after successful DNA. Now, while examining for the pericardial effusion and tamponade, it is very important to know that when the blood is actually unclotted, so that will exert a completely black shadow inside the heart. Whereas when it becomes clotted, it becomes a more echodense, just like your heart myocardium. So just like in this example, is immediately after shifting of your patient towards your ICU. So you have seen that there is a collection of your blood in your pericardial cavity, and also it is causing early RA collapse that you can see over here. Whereas after 10 minutes, you can see there is significant increase in amount of the blood uh, of the same patient, and also there is a definite RA collapse during your LV diastole. And after 30 minutes, the same patient, you can see over here, there is a formation of multiple fibrillary strand over inside this pericardial cavity. And you can see over here, the, the translucency of the tissue has become changed. So it is slowly becoming more like your myocardium. And there is a formation of definite clot in your RV inflow outflow view. You can see over here outside your RV. So this actually video loops. I have put it just to let you know that how this the clotted blood looks like, and also the how the immediate bleeding outside your RV looks like. This is another example of how the blood accumulates outside your of the heart inside the pericardial cavity, and it is also causing this increased blood is causing compression of your RV in your right side of image. Now, while examining the pleural collection, on your left side of the image, you can see over here, this is a left-sided pleural collection. Uh, so, in left-sided pleural collection, so how do you know is the left side? You'll be able to see the aorta over the image, and also you'll be able to see the tip of the collection is also towards your left side of your image. And you can see over here in this particular image, there is a collapsed lung that you can see, tip of the lung that you can see over here in this image. And this is the case of your right sided pleural effusion, and this lung is also collapsed, but here you cannot see any aorta over here. Now, prosthetic valve function I will more discuss in your prosthetic valve class, but for your rapid perioperative decision making, I'll just go through particular points that what actually you see actually in your prosthetic valve function in TE examination. That is number one, your stability, whether the valve is stable, it is attached in all its locations where if the suture has been put, and there is no rocking motion, and how is the strut is moving, that is how is the leaflet, that is your leaflet is moving of your prosthetic valve, uh, why, if there is any washing jet or not, and what is the gradient, if there is any patient processes mismatch, and if there is any pathological regurgitation. If that may be transvalvular regurgitation, and also that can be paravalvular regurgitation. So this is a normal mitral valve looks like. So this is a normal mitral valve looks like. You can see over here your mitral valve it opens and closes like this, and you can see over here this is your sieving ring. This is both side you can see, and the strut is moving equally, and both sides it is touching to the strut. And this is a colored Doppler that you can see over here. You can see over here your colored Doppler. This is a normal washing jet that can you can also see over this image. In the left-sided loop that you can see over here, you can see the leaflet is not coming up to the sieving ring and forming a transvalvular regurgitation. So that is inside your sieving ring, but this regurgitation is not washing it, is a pathological regurgitation. Whereas in the right-sided image, you can see over here there is a leakage outside your sieving ring. So that is your paravalvular regurgitation. These loops are example of post-mitral valve repair LVOT obstruction. You can see over here mediasophageal 5-chamber view. You can see the mitral regurgitation rate along with their flow acceleration in the LVOT. Is the same patient of mediasophageal long-acting view where you can see here your annuloplasty ring is actually impinging into automitral curtain and forming a constriction into the LVOT. And you can see over here there is a flow acceleration in your LVOT and your MRJ also. Thank you all for today. We'll join in the next class. Thank you so much.